Hi, my name is Charlotte Bishop. I am a master's student at National University, and I will be discussing a clinical trial using induced hypothermia in severe cases of bacterial meningitis. So first, I would like to give background on this study. Bacterial meningitis is an infectious disease characterized by inflammation of the protective membranes that surround the brain and spinal cord. Bacterial meningitis is often underlooked because it can develop quickly and cause sudden death within hours. Adjunctive dexamethasone therapy has been an effective treatment for adults, but the case fatality rate remains at 20%, highlighting the need for new therapeutic strategies. The use of therapeutic hypothermia in animal models of meningitis demonstrated very encouraging results, including lowering intracranial pressure, modulating nuclear factor K beta activation, preventing apoptosis, and potentially reducing cerebral injury. This study hypothesizes that hypothermia treatment would improve the 3-month functional outcome compared to standard care for human adults. This study was an open-label, multi-center, randomized clinical trial conducted in 49 intensive care units across France from 2009 to 2011. An open-label study is a type of study in which both the health providers and the patients are aware of the drug or treatment being given. In total, 98 comatose adults were chosen to participate in this study and were randomly assigned to different treatment groups. Randomization was done through the trial's website, which separated participants into blocks of various sizes to ensure balanced representation within the treatment groups. The eligibility criteria for this study was the participants needed to be at least 18 years of age, to have suspected or confirmed bacterial meningitis based on cerebral spinal fluid analysis showing either a white blood cell count of greater than 100 microliters, a cerebral spinal fluid glucose blood ratio of less than 1/3, a cerebral spinal fluid protein concentration greater than 2.2 grams per liter, a positive cerebral spinal fluid gram stain for microorganisms, positive soluble antigen test or PCR test for Streptococcus pneumoniae, or a positive cerebral spinal fluid culture. Along with that, the participants needed to have a Glasgow Coma scale of 8 or lower for less than 12 hours and received antimicrobial therapy. Exclusion criteria includes pregnancy, positive cryptococcal tests, the presence of brain abscesses, any complications that require therapeutic hypothermia, the lack of medical insurance, and if they are participating in another study. The hypothermia group participants received 1,500 milliliters of 4-degree Celsius cold saline infused over 30 minutes. An additional 500 milliliters of refrigerated fluid was infused if the temperature remained greater than 33.5 degrees Celsius. Esophageal temperature maintained between 32 degrees Celsius and 34 degrees Celsius for 48 hours with routine Center Pacific technique. There was a strictly passive rewarming phase required for all participants within this group. There were several statistical analyses performed. First, there was a sample size calculation where unfavorable outcome was expected to be 35%, an expected absolute risk reduction of 15%, which was based off of previous hypothermia results, with a significance of 0.05 and 80% power. The required sample size for this study was 276 patients. This study was set up in 3 interim phases. An analysis was planned after the enrollment of 106, 212, and 318 patients. Unfortunately, this study did not reach the required sample size, so due to insufficient number of patients, a chi-squared test was used to compare the proportion of patients with unfavorable outcomes. A secondary analysis was performed later on in the study. Survival was analyzed with Cox proportional hazards regression model. Survival curves were plotted using Kaplan-Meier method. Serum sodium concentrates over time analyzed using linear mixed models. Subgroup analysis was planned for pneumococcal meningitis cases, and all analyses were performed with a two-sided significance level of 0.5 using R software. The results of this study were inconclusive of sorts. The study was stopped early due to a higher 3-month mortality in the hypothermia group, which was approximately 51% versus the control group 31%. The study also had a relative risk of 1.99. No significant differences were observed between the treatment groups. All patients received the same mechanical ventilation, and the median Glasgow Coma Scale score was 7 for both groups. The high median simplified acute physiology score was 53 in the controlled group and 57 in the hypothermia group. 37% of hypothermia group and 20% of control group had septic shock. This sepsis in these patients attributed to meningitis causing organisms. In conclusion, hypothermia is not supported in adults with severe meningitis, as it has shown to not make any difference in their disease. Early termination of the trial may have influenced the interpretation of these results. The study did not assess potential adverse effects of hypothermia beyond mortality, such as cardiovascular complications, which could have contributed to their findings. Since the study included a specific population of adults with severe bacterial meningitis, it is not applicable to all patients with bacterial meningitis. The best study design for this case would be a randomized controlled trial, which was conducted in this study. Here are my references, and thank you so much for your time.